spending stays in the community, and we built continuity of care into that whole mechanism. So the folks that were coming through the doors of the Moffat County Jail, as they were seeing folks, ended up having a connection locally in the community. Once we did that, this is like the rabbit trail, like leading to where Medicaid-assisted treatment. I look at my job as the guy who looks at the horizon line, and what can we do to best provide services for the folks in our facility and the citizens that we serve. That's what led us to Medicaid-assisted treatment. We had providers now that were a part of our team that we knew, that we could interface with, and that we felt very comfortable with. That had the buy-in also from the local hospital, from a provider perspective, to be able to provide Medicaid-assisted treatment in the jail. So in late 2016, very early 2017, being a relatively early adopter, and certainly across rural Colorado, I think one of the first county jails to stand up a Medicaid-assisted treatment program, in large part due to dollars that were available through JBBS. If we were trying to fund this locally, I think it would be a lift that would be overly burdensome, and we wouldn't be able to do that. So we did that. We built that out. We actually brought on a clinician that is a part of my team that is funded through JBBS. Again, when we talk about some of the obstacles and some of the things kind of came together for us in like a picture perfect, if we were crafting the puzzle and we were responsible for all the puzzle pieces, it just worked. But again, back to the rural Colorado aspect of that, the two biggest obstacles that we continue to face are resources and funding. Have you talked about that so far, or your area of expertise where you come from? It's how do we get the dollars? More importantly for us in rural Colorado, if we had a big bucket of money, we're resource poor. So that standpoint of having providers within our community that we can bring into the program, that we have available for when folks leave our facility, is not like it is along the I-25 corridor. So we've had to work really diligently with our partners. So we have a group, Providence Recovery, which is tied to our local hospital that is up and running. And so we have a really super cool, strong, robust resource for when those folks who come in become a part of our Medicaid-assisted treatment program, that they have a connection as they leave the facility, so they're not just walking out on their own and then have that, unfortunately, that relapse without a support system built into that. So that's kind of how things have worked for us in Moffat County with the pieces coming together. And it goes to some of the things I heard from the group from Larimer and Weld. It comes into relationships and fostering those relationships locally and being able to come to the table and figure out how can we make the things happen that we would like to see, right? We establish goals, and goals oftentimes fall into a couple of categories, right? Wants and needs, right? Wants are, if everything being equal, we could do whatever we wanted to, this is what we want, right? It's the gold-plated standard of whatever, fill in the blank, in this case, Medicaid-assisted treatment, but we have to be realistic. But what do we need? What do we need, and then how do we bridge the gap between the need and the want? And I would offer up that we're doing things really well in Moffat County. Again, not due to anything that I've done. It's amazing people that are a part of our team that come to work every day, spend time, energy, and effort, and do things that are truly beyond compare for me. And it makes me really proud of the things that we have going on. So am I on point, relatively pretty close to where we're going to go? Okay. All right. I think so.
That is a tough act to follow, but I'm going to give it a shot. So thank you. So my name is Lesley Brooks, and I wear a number of hats, none of them worth talking about this morning. I am standing in for Lieutenant Stacy Schaefer, who is just, much like Sheriff Hume, has just been an incredible champion for medication-assisted treatment and the treatment of substance use disorder in our Larimer County Jail. We could not have done what we have done in Larimer County without her working as a champion, and unfortunately she wasn't feeling well today. So I am going to do my best to represent Lieutenant Schaefer and the work of our Larimer County Jail. Very similar to the work in Moffat County. It took, you saw 7 of us sitting up here, in part because it demonstrates the incredible partnerships that it takes to pull off something like this. And Lieutenant Schaefer frequently refers to the stays in her Larimer County Jail as a stop-opportunity. And she wanted to make sure that not only could the jail offer opportunities to break that cycle, but she also understood that she needed the rest of the community to come along with her. And she really wanted that. She said, this is not any single entity's problem to solve. We're going to solve this because we come together as a community. And the average stay in the jail is short. She knew that too. The average stay in the jail is short. And so she said, look, beyond the walls of the jail, we're going to need support for people to continue in their journey of recovery and hopefully break the cycle, the revolving door that sometimes can happen with incarceration. So just a very similar story to Moffat County. So I won't repeat all of that, but some of the highlights that I hear Lieutenant Schaefer talking about include one, the jail working together with the community. The jail really wanted to bring in the community to create protocols. We have a great photo of a bunch of us community members, probably at 7 a.m. inside the jail, working together on a whiteboard and figuring out what the workflows would be. MJ was part of that. And figuring out how do we go from booking, how do we assess them in booking, how do we get ultimately the jail's third-party healthcare vendor identifying these individuals who needed medication-assisted treatment and then deploying that care to them. How do we educate our jail staff so that they understand what the protocols are and the workflows are? It is different. I think you highlighted this, Rob. This does not look like a primary care setting. You don't just move people around in a jail just because you want to. That takes quite a bit of thought process and work going into that, and lots of people cooperating. So we had multiple sessions, whiteboard sessions, to sort of figure this out. We knew that we needed care coordination, so the jail really wanted to partner with COAC, and so we deployed one of our care coordinators that's supported by that grant. We had another grant through the Denver Foundation, I think, to provide the support that we needed for the additional medical providers in the jail. Thank you, MJ. I see their head nodding down there. To really bring together the team in the jail to make this work and to provide the supports in care coordination to get folks appointments outside the jail and to help them navigate when they leave the jail, getting to those appointments. We also used funding to contract with the Butler Institute, who you saw gave us great data on our COAC project. We have similar data around our MAT in jail project that helps us to understand. We have one more year, MJ? It's this cycle that we'll have the final round of data to help us understand the impact of all the work that we have done on that revolving door. So more to come there. The jail was committed, and we were committed to all 3 forms of medication-assisted treatment, which meant that we worked with our local providers and we worked with our local OTPs to ensure that we had guest dosing available. I'm not sure that we're at the point quite yet where we're doing inductions on methadone inside behind the wall, but certainly anybody who comes in on methadone, we are working hard to make sure that they can continue that medication. A shout out to our MSO Signal and to our Larimer County commissioners who really supported putting this with the dollars that we have available and then figuring out a glide path to put this into the budget so that it doesn't go away just because the grant funding goes away. They were committed to harm reduction and making sure that everyone has naloxone at release. And I think with that, that's the hit parade. So happy with my crew down here to answer any questions that you might have.
Please, go right ahead.
Seen happening. I haven't had as much experience with people being, released on Suboxone, but when they're on mental health drugs in a jail, they are released without their medications, no one to pick them up, no housing, no phone. At times of day when services aren't even open, they're told to, go over and report to Longmont, and you're being released from Boulder. And they're released without adequate clothing. Sometimes they were arrested in July in shorts and a t-shirt. They're being released in February without adequate clothing. They aren't allowed to go straight into treatment. If they do have someone allowed to pick them up and take them to treatment, because they've got to report to parole or probation, and they are, released without identification, without a car, and it's just not functioning. They get completely overwhelmed before they could possibly get back on their MAT treatment. It's not working, okay? So it might sound great to have them on all these things in jail, but they're ripped off of it the second they get out. And they relapse before they get to where they need to get. So it's just not working. Thank you.
Shall I sing? Oh, right. Those are facts, right? I mean that is that you're not wrong about that. That is the reality for many who are released from our jails, whether they have a substance use disorder or a mental health disorder. That care coordination can be incredibly challenging to stitch together, and it's a global systems failure, right? It's not just one person. It's not just the jail's workflows. It's not just our workflows in the outpatient setting. It is multiple workflows that conspire together to create an equation for disaster, overdose, and death. And I think one of the things that and Jose's got his hand up back there, one of the things that we learned in our process in Larimer County was that if we had the opportunity, we would have invested even more in care coordination. We would have invested even more in the number of hands that could take somebody as they walk out of jail and say, come on, go with me, because I can help you navigate this system. So dollars available for care coordination.
So on the care coordination piece, and again, I think valid points, some of it is scope, right? So the things that happen in Larimer Weld from a size or a scope perspective are much different than happen in Moffat County. What I can offer up with the process and the system that we have in place in Moffat is that we have about a 95% connection rate with that care. And we've have follow-up, continuing follow-up through our clinician and our staff that are tasked with that, of following those folks along. A big piece of that goes back to the original contract and having a continuity of care with our providers, because again, Craig is a small community, but the folks that are providing the inmate health care are also the folks that are providing the aftercare when folks are outside of the facility. So we have that connection piece. Again, it's scope, and I hear what you're talking about. Jose?
Is it on? There we go. Hi, Jose Esquivel with the consortium. What this issue at hand that you're speaking about is around continuity of care, and I want to point out that in the recent fentanyl bill, it is now mandated that jails provide that continuity, or work to, or with providers on that continuity of care. And we'll take a look at that statute, get it out to you, but here's the thing. We are working with jails to help make that connection, but you all can also do some planning with your opioid settlement funds to help create that continuity of care. This is why we're working really hard to expand MAT, make sure MAT is available, but that warm handoff takes extra effort and people. Perhaps that's something you can consider using your opioid settlement funds, is to help fill that gap.
I want to comment too. So JBBS, those are things that JBBS can pay for. Not everybody in a jail is on JBBS. JBBS is a voluntary program, so depending on the size of jail, it may be a small portion of folks that's actually on JBBS. But I tell all of my jails, I don't want anybody released without boots, without gloves, without a tent or tarp or a bicycle, some mode of transportation. I don't want anybody released with those things if it's something that JBBS could pay for. So we try to make that clear with all of our jails, that even if they weren't on JBBS, if it's release them in a pair of flip-flops in December or buy them a pair of boots, buy them a pair of boots. So we try to make that clear, that that funding can be used to help folks, not just in JBBS if we need to.
And we do that in Moffat. We've bought tents, we've bought boots, we've bought parkas, we've bought cell phones, we've fill in the blank, the things that those folks need.
We had one or two more questions. Wanted to get to the two that had their hands up. Commissioner?
I just have a quick question for you. You're from Moffat County, you're from a rural county. Can you do us a favor and help educate some of the rural sheriffs of the benefit of your program? Because looking at criminals as criminals, and the JBBS, and I was on the committee originally, and I still am, but they do coordinating committee meetings instead of original meetings, which I'll talk to you guys later about. But please, at the Sheriff's Association, treat that to bring in, as you have brought in all of your community members to be a part of that. Change the old way of thinking of these people that need help, and it changes the dynamics of our community, and maybe giving some of these people a second chance. And I beg for that, because in Southeast Colorado we don't have that. Thank you.
Thanks, Commissioner. Appreciate it. One last question. I know we were counting the four that may have been missing, please.
Hi, I was curious about the medically assisted treatment. Do you find that it's also an issue with other maybe co-occurring situations, if you have an epileptic who also needs medication, or if you have a diabetic, a person with diabetes? Is the funding, first of all, Becky, just relegated? Do you find that you have to split your funding and it only addresses SUD or addiction, or is there a way that you've seen to work that together?
We can work it together. So generally those non-mental health, non-medication assisted treatment medications, so epileptic medications, if it's not a mental health medication, psych medication, that would have to be paid for elsewhere. But any type of, medication assisted treatment, or if it's a mental health medication, that's something that we can pay for. But we have paid for some of those medications as well that are just medical when the client is indigent or something else is going on. Those are case-by-case situations that, somebody from Moffat County may email me and be like, hey, Becky, is this something we can pay for? This is the cost. Yep, here you go. Here's your email approval saying yes, go for it. Yeah. We want to be flexible with our funds. We want to make sure folks get what they need.
Okay, thank you.
It's so cool that Becky talks about things that we have actually done.
Hi, my name is Corey, and I'm from Montrose County. I have a situation where I see people getting pretty good care through JBBS, but then once they're released, they're not, they're getting injectable buprenorphine, and that's not something that providers in my community can provide. So there's a big drop and lack of continuum due to coverage for medications. I guess my question is can some of your funding follow them into the community corrections realm and get some of those things paid for?
Yes, so as long as somebody continues to participate in treatment, we could fund for up to a year. So our clinicians generally in the community we ask them to, and they are, in order to follow their contract and make sure they're getting their funds, they need to follow up with clients at every 1 month, 2 month, 6 month, and 12-month intervals. And as long as folks are still participating in treatment, still going to see their therapist, we can continue paying for treatment. We can continue paying for medications. We can continue paying for housing. We've paid for inpatient treatment. We've paid for hotels. We've paid for bus passes still at the 12-month mark. Those are things we can continue to do. And I can talk with my Montrose County folks as well. And something we're trying to do with our counties is, hey, if the medication isn't available in the community, we need to try to get them something else while they're in the jail. So if they come in on a medication or they get put on a medication while they're in the jail, we know that that medication is not available in the community. Let's try to transfer them to something else. Methadone has been a huge one. They'll be put on methadone in the jail. Not a lot of jails do that right now, but with the fentanyl bill, we have to have it, so we're working on it. And so if they're on methadone, if there's no methadone in the community, what can we get them on before they go to the community so they can transition out on a medication and have that medication available within the community? So that's something we're working with our jails on a lot right now.
Thank you.
Thank you.
Awesome. The last thing for me, I would like to thank, obviously, the panelists, right? It's so pleasure to meet both of you. And Rob for keeping us relatively on track. If anyone has an inkling, a desire to reach out, MoffatCountySheriff.com. There's a picture of me probably if you get to that site. Feel free to reach out, whether you have a question we didn't get to today about Medicaid-assisted treatment, something else, or you want to come up. We're happy to give you a tour, see what we've got going on in the facility and with our team and all the rest of that. So I thank you all very much.
Thanks, everybody. Appreciate it. Appreciate all those questions. It's obviously a super important topic, and please do get in touch with them afterwards. They'll help you get started.
So I figured out Becky's title. Becky's title is the director or manager of everything JBBS. So just call Becky. We'd only met on Zoom 1 or 2 times, so I was like, I don't know what her title should be, but now I figured it out. So thank you so much. Thanks, Dr. Brooks. Thanks, Sheriff. Really appreciate you all so much.